new Facebook page, relatively new because many of the members of the AOMPT or the routine course participants of the academy would not have been aware of this page for a long time. And I just gave the invites to like the page, and then I am starting this webinar so that people who join in accepting my invite, so they have the opportunity to immediately listen to me. Of course, my friends list, and also the AOMPT Facebook page is multinational. Okay, so you can see so many countries, people are there. And this is part of the series of the webinars, the free webinars, exclusively 100 free webinars conducted by the Academy of Orthopedic Manual Physical Therapists. And I am planning to conduct, some of these webinars relevant to those pages. So in that page itself I will conduct, so that it's not the AOMPT page alone that is getting reach. Every page can grow by the content that is provided not only by the academy but also by the participants and also the posts from the visitors. Okay, so that's how we have a teamwork and interaction of information, exchange of information and knowledge. Okay. So this webinar, manual therapy for shoulder pain. Previous webinars in this series included the mechanism-based clinical reasoning for pain and manual therapy for pain using mechanism-based reasoning. And of course, the major part, the manual therapy for the neck pain, which was also part of the certification in spinal manual therapy, the course of the AOMPT. And following up from the neck, we also had the manual therapy for back pain, okay, which was also part of the CSMD course. And now we are having after the neck, it's the upper extremity. So we are starting with the shoulder. Shoulder is something which is a very special region. For all of us, we know the extensive anatomy and also the extensive functional biomechanics. Okay, so what we see as an interaction of these four joints, the sternoclavicular, acromioclavicular, scapulothoracic and glenohumeral, which plays a major part in positioning the upper extremity for the functional activities and also to generate the force for sports, or what is called as the generation may be from the core, but the transmission will be from the shoulder complex, okay, to the upper extremity. So from lower extremity or the torso, if the force is generated, it will be delivered to the upper extremity through the shoulder complex. When we talk about the manual therapy, always the impairment based reasoning comes into the picture. So articular, myofascial and the neural impairments around the shoulder and how we can address them. Of course, parallelly the clinical pattern recognition. We had seen the major clinical patterns of three distinct presentations. One is the frozen shoulder, or extending into post-traumatic stiffness, or it can be osteoarthritis of the shoulder. Okay, so it's a spectrum there. And then impingement syndrome, which might start with a tendinitis or bursitis, or it might be with a strain or the sprain of the ligaments and the tendons there, including even myofascial trigger points of the muscles of the shoulder, and altered motor control around the shoulder complex. Okay, so everything, it's a myofascial mainly. That is the impingement syndrome, okay, and other soft tissues other than the myofascial system. The impingements can be again internal impingement if you are talking about glenoidal labrum getting impinged, okay, or the capsule or the synovial membrane is getting impinged within the joint, maybe it will become intra-articular. Otherwise, most of the time it's periarticular. What you have in the third category is the instability. Okay, so you have this clicks, you have this subluxations, you have this hypermobility which are asymptomatic to leading to dislocations. Okay. Trauma, definitely, it's of course, it's not per se, you cannot say fractures are contraindication for manual therapy, but because the healing state, okay, so and what extent you are doing the manual therapy, okay. There are manual techniques which do not involve the movement of the joint, so that will not be contraindicated in the event of fractures. Okay, only we need immobilization, that's all. We can also treat the neural system at the shoulder by moving the elbow or moving the wrist, or moving the contralateral upper extremity. So you cannot tell fracture of a surgical leg contraindicates neural mobilization. Okay? In general, as a vague terminology, you cannot talk because you are concentrating on treating the patient, not just treating that area. Okay? So even myofascial releases, the myofascial kinetic chains, we can influence the shoulder fascia by mobilizing at the thoracolumbar fascia. Okay? So either way, you are getting a picture where the body regional interdependence is also there. You can treat the thorax for the shoulder. Okay, there are various options. So we are going to see what basis and what are the manual therapy options, the techniques which are there, and how are we going to plan into the clinical picture as we are taking, for example, the posture deviation in the shoulder, a scapular dyskinesia, or abnormal position of the humeral head, okay, and how it will dictate a particular manual therapy technique depending upon the associated findings. Okay, because we don't go by just one single finding and then say that you have to give this manual therapy technique and it will be effective. Because there is no clinical prediction rule as such which tells that strong evidence that one clinical presentation will indicate a particular therapy and the patient will become a responder. Okay? So you need to know that limitation of the reality. Okay? I might have right shoulder pain, I might have left shoulder pain, but both the shoulder pain is similar in terms of maybe pain, but it may not be similar in the terms of the cause for the pain. Okay? Because functionally one is dominant, other is non-dominant. So definitely there is a lot of difference. So try to identify the uniqueness in every patient. Okay? This webinar is not a substitute for a direct consultation with a physical therapist. Okay? So patients who are watching this webinar don't think that you just can take some therapy, you can take this technique. Okay? No, you just have to take a good therapist. Okay? And they will decide what is best for you. Example, scapular dyskinesia. Okay, so we have this type 1, type 2, type 3 Scapula, which starts with the inferior angle being prominent, or you are talking about the medial border being prominent, or the superomedial angle being prominent, okay, of the scapula. And this dyskinesia is more of a dynamic one, which is related to the muscle imbalance. As I am mentioning this as a muscle imbalance itself, you can imagine that it's actually a motor control issue. So patients have to be evaluated with what is called as the scapular assistance test. So during the movement testing, you are going to do the scapular assistance test, and if that provides relief of the symptoms, you are going to indicate a scapular mobilization with the glenohumeral movement. So that will directly go into the Mulligan's mobilization with movement. The next part is scapular stabilization test, where you are actually applying pressure scapula to the chest wall, and you find that the symptoms of the shoulder or of the scapular region is becoming better. In that situation, it will indicate definitely a stabilization program, which is not just the isometric exercises, it is the activation of the stabilizers of the scapula, which might involve the middle trapezius, and also later it is the serratus anterior. Okay? Especially for the type 2 Scapula, where the medial border is prominent, you need to go for the serratus anterior strengthening. But that strengthening will be low load strengthening, that strengthening will be close kinematic strengthening, and that strengthening will be predominantly for endurance. Okay? So that's the difference between mobilizer strengthening, which is like progressive resisted exercises, versus a stabilizer strengthening, which is more of a postural control. Okay? Scapular restricted mobility, okay, which are most of the times it is part of the frozen shoulder, where particular directions may be restricted, particular directions may be mobile, excessively mobile. Okay? Otherwise, the scapular stiffness, maybe an old fracture of scapula, or you have a surgery to the thorax and you had like posterolateral thoracotomy, or you had scoliosis, for example, the spinal deformities, which can have this asymmetry, so the scapula has gone into a restricted mobility. However, every restricted mobility is going to be myofascial in the beginning. So your evaluation will focus on the palpation. So remember that not just the positional abnormality, you have to see for if the scapula is superiorly placed, is the upper trapezius overactive spasm, or it is overactive and it is hypertrophied, okay, which is more of an indication of adhesion or tightness, okay. And then next one you see for the lengthening of the tissues, the depressors, which are actually more atrophied. Okay, so both the soft tissues, both the sides, you will try to see if there is a direction of deviation towards the direction, what are the soft tissues abnormalities, away from that direction, the antagonistic soft tissues. So those, what are all the abnormalities? Okay, this is what your prime focus in palpation. Because a tissue which is lengthened and atrophied, you will actually give a strengthening. But although initially you give concentric strengthening, you will give eccentric strengthening, which is very, very important to prevent it from further lengthening and then getting injured later. Okay, it's because of the altered proprioception. The muscle is not able to detect that it is there in the outermost range. Okay, and it goes for a strain and it develops a trigger point. Okay, and then it has a spasm. So definitely these lengthened muscles, for example, if it is rhomboids which are lengthened because the scapula is protracted, okay, where the subject is forward, upper extremity forward and then doing activities, okay, scapular protraction is more common. If it's only upper extremity. If the spine is going for slouching, okay, unsupported back, and then there is an activity, then what happens is scapula goes into anterior tipping. Okay, this anterior tipping shortens the pectoralis minor. So your soft tissue techniques might be addressing the pectoralis minor in release and also the post isometric relaxation techniques, whereas posteriorly you will concentrate on the rhomboids, which will be initially concentric, later it is eccentric strengthening, and the stabilizers, which is the middle trapezius, which will be endurance. Okay, and once the middle trapezius is strengthened, then you co-activate the serratus anterior and make the patient to do some wall activities. Okay, like for example rolling a ball on the wall, for example. Okay. These are all discussed also as part of the functional neuromuscular stabilization training, the FNST course of the AOMPT, okay, so which is going to be held in a few days now, from now on 14th March 2021. So motor control retraining is not just regional, it is more global, and it is not just musculoskeletal, it is multisystemic. And especially it is not just presently done, it is part of the developmental sequence. How did we develop the motor control? In that same pattern we have to train the subjects so that irreversible long-term functional recovery could be predicted. Okay, so that's why FNST is an exclusive approach of the AOMPT. Okay, I will give the details in the description here so that participants can enroll into the course and receive the videos and get certified. Okay, it's available online and also offline. So coming from the scapula, if you are talking about the neural impairments, the most important neural impairment there for the scapula, which is the suprascapular neuropathy. Okay, it's mainly because of the scapular protraction, which provides traction to the suprascapular nerve, and that nerve supplies the supraspinatus. Okay? So if suprascapular nerve traction goes to a level where it damages the nerve and it weakens the supraspinatus, you know the consequences of that. Okay, so either supraspinatus itself can go for tendinitis, or the weakness of external rotation might cause an impingement, because when external rotation is weak, internal rotation is going to be overactive, subscapularis may be overactive, leading to the impingement syndromes. Okay? So remember that this is something which is commonly found in swimmers and throwing athletes, where the protracted shoulder is associated with suprascapular neuropathy. In the neurodynamic testing and neuromanual therapy, okay, it's an exclusive approach of the AOMPT. We had the certification course in neuromanual therapy, CNMT, we concluded last week, this Sunday. And the course is also available online and you can get certified, okay, you can enroll to that. The main component is the ULNT2, the median nerve neurodynamic test, where you add on, in addition to the shoulder girdle depression, you will add shoulder girdle protraction. When you add shoulder girdle protraction, suprascapular nerve is going to be tensile loading. Okay, so you can correspondingly do the Tinel sign, whether you want to provoke, the position should be provoking the symptoms or position should be offloaded and relieving the symptoms. You can also give the nerve massage to the suprascapular nerve at the suprascapular notch deeper to the upper trapezius. And of course, the sliding techniques, the sliders, which can be given by altering the addition of the sequence. Okay. In terms of we had a minor interruption. It's not a technical interruption, it's a human interruption. Okay, so and then I'm resuming back. So I wait for the participants to join back. We were seeing the manual therapy for shoulder pain, and after discussing about the scapular abnormalities and then the various manual therapy options, I'm going on to the glenohumeral, where I was discussing about the impingement syndromes. Okay? Because alterations of the kinematics and then altered loading of the myofascial system leading to a chronic or a repetitive strain, where the injury to the soft tissues in terms of tendinitis or bursitis. Okay? Bursitis, repeated compressions. Tendinitis because of repeated tensile loading or eccentric loading. Okay, so always you see in terms of the mechanism of the injury. When you are talking about this impingement syndromes, okay, there are impingement which can happen in the mid arc of the motion or in the end arc of the motion. So if the impingement happens in the end arc, okay, the last 30 degrees of the elevation, then you can be sure that the impingement is because of sternoclavicular or it's because of acromioclavicular. Okay? So in that situation, in an active movement testing when you are doing, you are supposed to do the MWM to the clavicle, because clavicle influences sternoclavicular also, acromioclavicular also. And definitely you will get a better response. And the other factor is of course the glenohumeral painful arc, which comes between 70 to 110 degrees, around in and around the 90 degrees, and that is mainly because of the longest lever. Okay, so there the rotator cuff is not working. So attempt to activate the rotator cuff. Okay, there is a test called as dynamic relocation test. Okay, so when the patient is getting painful arc, just get it before that and then activate that. About the dynamic relocation test also, it's part of the FNST, Functional Neuromuscular Stability Training, the upcoming program of the AOMPT. So what you need to do is, you find that the reactivation of the rotator cuff helps the patient in terms of reducing the painful arc. Then you are going to give that as an exercise, and of course the strengthening in the scapular plane. Okay, so that is important for activating the rotator cuff throughout. Okay. It's not just one direction. Rotator cuff are direction independent. Okay, they are dynamic stabilizers. So that's the role there. And once that is done, the humeral head superior migration, too much excessive migration will be prevented, because the lower cuff will counteract that, especially the teres minor and the infraspinatus. Okay, subscapular is also. And of course the internal rotation, which can cause the impingement, another pathomechanics. So you need to see that external rotators being strengthened. After the stabilizer strengthening, go for the external rotators strengthening program. Okay, that is again concentric strengthening. And then you go into the strategic management, where you are seeing in terms of bursitis or tendinitis, there is a local soft tissue adhesions, okay, during the healing phase. So when you palpate, there is tissue thickening, there is some kind of a crepitus, okay. Patient is having what is called as very intermittent symptoms, okay. After long activity, the symptom is getting provoked. They are best candidates for deep transverse friction massage, okay, as the description of James Syriacs, okay. And subsequently, when you progress, okay, from the impingement syndrome in that spectrum itself, you have nerve impingements, okay, which can also happen. In fact, in the actual shoulder impingement syndrome itself, you have subcoracoid impingement and subacromial impingements. Both are there, and you might see that there are some axillary spaces around in the axilla, like upper triangular, lower triangular, and the quadrangular space for the axillary nerve. Lower triangular is for the radial nerve. Okay, so various nerves are coming out through the axilla. So there can be entrapment of these nerves because of the myofascial imbalance. So that might again produce or indicate a neuromanual therapy. Okay, basically, what you actually do in this spectrum of patients who are with impingement syndrome is, initial phase, try to see improve the motor control, and later you try to correct the muscle imbalance by muscle energy techniques, okay, and then go to the deep transverse friction massage for adhesions and also the myofascial releases or the fasciomuscular releases as a progression, and then go to the neural techniques. Okay. If the symptoms are neural, you will start with the neural technique as a priority. Okay, first. The next, coming to the frozen shoulder or the post-traumatic stiffness or osteoarthritis of the glenohumeral joint. Remember that this restriction of the shoulder, how much range it is restricted, that is important. Earlier I have told you the contribution of sternoclavicular and acromioclavicular 30 degrees. Combined with the scapulothoracic, it is 60 degrees contribution is there. So if the total range of the subject in elevation, if it is 120 degrees, okay, there is a 60 degree restriction. Definitely you can suspect that scapula, sternoclavicular or acromioclavicular is abnormal. That's why 60 degree restriction is there. Okay. If the restriction is only 30 degrees, okay, you can suspect that only sternoclavicular or acromioclavicular alone also can be affected. Scapula may not be affected. It may be just compensating for the stiffness in the acromioclavicular or the sternoclavicular. Okay. Whereas if it's only 90 degree range, you have a loss of 90 degree, you should suspect definitely that glenohumeral is also stiff and restricted. Not only this clinical picture, what is the initial picture, we have a differentiation test, Scapulohumeral differentiation test. So that is explained under the differentiation based physical examination and movement testing in AOMPTs, where you can identify each of these components, how they are actually cause for the shoulder symptoms and also the range restriction. Okay, so all these four can be clearly differentiated kinetically and kinematically. Okay. The importance of kinetic differentiation is muscles control protocol and re-education. The importance of kinematic evaluation is actually for the mobilizations and the what is called as releases. Okay. So in the frozen shoulder, you might think of the painful stage. Okay. The initial painful stage is too much troubling for the patient. So what is to be done? Remember, there is absolutely no contraindication. Even if the muscles are not able to activate, you should try motor control retraining. Okay, first and foremost before going for mobilizations. And distraction mobilization definitely will help these patients. And what else you can do effectively is to address the thoracic spine. Because these frozen shoulder patients, most of the times they have regional interdependence, like thoracic flattening of the kyphosis, okay, or it could be core stability weakness, okay, which can be evident even in impingement syndrome, okay, the lumbar core stability, okay, that issue. And next, of course, is also if there was a previous problem of thoracic outlet or cervical radiculopathy, okay, so that can create a shoulder. Even post-operative CABG, the coronary artery bypass graft, they develop a thoracic posture. After that, they develop shoulder impingement syndromes, which are neglected, which leads to the frozen shoulder. Okay. Initially, the impingement syndrome was actually termed as the periarthritis shoulder. Okay. And when it becomes that the capsule fibers get interlinked and can go for adhesions, it was called as adhesive capsulitis, which could be detected by arthroscopy. Okay. Adhesive capsulitis definitely will indicate capsular stretches and also mobilizations, which are like grade 3, 4 end range mobilizations. Okay. Whereas when you progress in the frozen shoulder itself, you will go ahead with increased grades of mobilization. And of course, the two tests which were described by Maitland, the quadrant test and the locking position, both of them will be very useful for mobilizing. Okay? And rest of it is actually left to the frozen shoulder being affecting either the radial nerve posteriorly or it is going to affect the median nerve anteriorly. Okay? Because the humeral head migrates anterior and superior. Okay? Most of the times you will find the frozen shoulder, you will find the humeral head is prominent and it is superior. So inferior glide will help, posterior glide will help in the flexion. Okay? And of course radial or the median nerve neuromanual therapy. Okay? So always remember this picture will be very clinically useful. Okay. Of course, there are various other treatments. You can go ahead with anything else. Okay, you can do scapula mobilization. You will do only if the scapular lateral rotation, which will be restricted commonly, okay, with arm elevation in abduction. So there, lateral rotation mobilization is needed. Don't mobilize the elevation of scapula because patient is already having hypermobility. Elevation only is the trick movement. Okay, when they do the shoulder abduction. Of course, the Codman's pendular exercises, all these are the initial phases. Okay. When you come to the instability, it is a passive dysfunction in terms of capsule or the attachment of the labrum. Okay. So it can be traumatic or it can be atraumatic. It is unidirectional if it is traumatic, it is multidirectional or inferior subluxation if it is atraumatic. The atraumatic is usually because of neuromuscular disorders, including the stroke where you get a shoulder subluxation, inferior. And anterior or posterior dislocations or instabilities are common in trauma. Fall on outstretched hand, where you have the direction of force is posterior, will go for posterior dislocation, but it's very rare. Anterior dislocations are more common. And most importantly, epilepsy or electric shock, these all things will create the posterior dislocations. Okay? So your method of management for this instabilities and dislocation predominantly revolves around the 3 weeks of protective phase, conservative means. Okay, so in that phase, don't try to give too much of dynamic exercises. Whereas initial phases, you will start with motor control and also closed kinematic chain exercises and improve the proprioception. Okay, use diagonal patterns and use joint repositioning error so that the subject will not go too much excessive external rotation. Okay, if it's a throwing athlete. Okay. And so a lot of factors and also adjunctive rigid taping in order to limit the end range of movements, okay, in the instability. For example, anterior instability gets provoked with external rotation, whether it is in neutral, superior glenohumeral ligament. At for example 60 degrees abduction and then external rotation is middle glenohumeral ligament. And 120 degrees abduction and then external rotation is the anterior band of the inferior glenohumeral ligament. So various components get actually tested, or they are responsible for controlling the humeral head translations in the anterior direction. So this situation, you also should see that which ligament is actually strained and which range you are supposed to give the stabilization program. Okay, don't just give a pillow and then push all the directions. Okay, in the neutral, nothing is going to happen. Okay, and to compensate for the ligament or the capsular laxity by motor control, okay, conservatively. It depends on the extent of the injury. Sometimes the anterior glenoid, the Bankhart's lesion, or the posterior-superior glenoid, the Hill-Sachs lesion will worsen the dislocations, making it recurrent. So you might need a surgery. Okay, and post-operative, definitely the mobilizations will be much better. After the first week, you can go for aggressive mobilization and proprioceptive training. Okay. What is here in terms of this instability is a picture where you have an instability of glenohumeral. Because it is unstable or it is hypermobile, scapula becomes stiff. Then also you can go for the scapular mobilizations, but you will mobilize the scapula after enhancing the stability of the glenohumeral, then you will mobilize. Okay? Because to enhance the stability, you want the rotator cuff to act, scapula has to be stable. If it is stiff, it's actually an advantage. So you can develop this muscle control. After which you can go for the mobilization of the scapula. Okay? And sometimes the posterior capsule tightness will worsen the anterior instability. So it's like asymmetrical capsular tightness. Okay? So there again, posterior capsule stretches in horizontal adduction and internal rotations, or with the posterior push. All these techniques will be of use. Okay? You can evaluate the internal external rotation total arc and identify the glenohumeral internal rotation deficit, and then give a hold relax and differentiate between whether it is medial or rotator tightness, because of which internal rotation is more, or is it the what is called as the posterior capsule that is tightness, okay, which is limiting the internal rotation. So you might be having an abdominal internal rotation. Okay? So sometimes the teres major, the posteriorly there, but it is a medial rotator. Okay, and you also have the teres minor, which is a lateral rotator. Okay, both can be tight. Whereas the range is different. Teres minor influences at the arm in the side, okay, to restrict the internal rotation. Teres major produces the internal rotation actively in 60-degree abduction and then internal rotation. Okay, so try to see for myofascial trigger points in the teres major if the teres minor is tight. Okay, posterior capsule is tight or with the teres minor is tight. Teres major goes for the active trigger points. Okay, so you might have to release. The similar situation trigger point can happen in the subscapularis trigger point in an anterior instability, because the muscle is trying to work more in order to provide the stability. Okay? External rotation is going to cause the anterior instability, but the only restraint is the subscapularis. So subscapularis is working too much and it develops the trigger point. Okay? So that again has to be released. Remember that this kind of release, because of an overuse or because of lengthening, you should not fully go for a release. Okay, you should parallelly go for the activation patterns and go for eccentric training, okay, for these muscles. That's why incorporating fasciomuscular release will be more important than just myofascial releases. Okay, and instabilities, whether neural, maybe to some extent, because external rotation is excessive. Anterior humeral head translation will affect the median nerve, which is just anterior to the shoulder. Posterior instabilities definitely will affect the radial nerve. Okay. Inferior instabilities or subluxations might affect the ulnar nerve. Okay. So correspondingly, you can do the neurodynamic testing, and then you can go for the neuromanual therapy options. So I have given an outline. I have tried to touch upon various aspects, right, from sternoclavicular, acromioclavicular, scapulothoracic, and also the glenohumeral. And I am opening the floor for the questions so that we can have some interaction. People who have liked the page recently would be seeing the notification that live, and you might watch the video later. Please put your questions in the comments. Of course, I am also referring or recommending all of you to join the video-based online courses. So those courses also I will just list it here in the description for this video. Okay. So over to the members, we have Dr. Ritu. Okay, she never misses any webinar of the AOMPT. Okay, as much as possible. So it's a pleasure to have Madam with us. If Madam has any question, okay, she should first text that one question, okay, and then start typing next comment. Okay, so that seeing that question, then I can wait, because usually the question will be a big question, so it will be more in depth for a clinical perspective, okay, in a particular patient, okay, how we can decide a particular manual therapy and or a progression, for example. Remember the approaches of AOMPT, we have lot of approaches, and we have extended it also to ortho, myo, neuro, manual therapy. That means combining articular, myofascial and neural manual techniques simultaneously in different sequences. Okay. So it's an all-in-all technique. Okay. It will be useful for every type of spectrum, whether it is frozen shoulder or it is instability or it is impingements. So if you are ready to wind up, then we can close this session and wish everybody the best of luck. The next webinar will be on the manual therapy for elbow pain, where we will concentrate predominantly the lateral epicondylalgia, middle epicondylalgia, and also the associated elbow clinical presentations. Right? So, see you. Bye bye.